Yeah, so there's nothing you need to do.
I'm Dave Wooldridge, and it's my pleasure to introduce our speaker today. I want to get started because we may have a hard stop at 1. I think there might be a class in here at 1 o'clock, and I want to allow some time at the end for questions. So you're here for the Goodson Lectureship, and I want to give you a little bit of historical background. The Goodson Lectureship was established in memory of Dr. William Goodson, Jr., a longtime internist in Kansas City. He was born in 1909, the son of William Goodson Sr., a family physician who practiced in Liberty, Missouri. William Jr. was a Phi Beta Kappa graduate of the University of Missouri and a 1934 graduate of Harvard Medical School. After service as an intern at the Hartford Hospital in Hartford, Connecticut, he returned to Liberty to practice with his father for a year before going to the Mayo Clinic for a 3-year fellowship in internal medicine. He then returned to Kansas City, where he practiced general internal medicine and rheumatology from 1940 until his death in 1985. He practiced at Trinity Lutheran Hospital during his entire career. Among other affiliations, he was a UMKC Year 1 docent from 1980 to 1982. For Dr. Goodson, medicine was his true avocation as well as his vocation. Like his father, who practiced until age 82, Dr. Goodson saw no reason to quit, and he saw 10 patients in his office the day before he died. By all accounts, Dr. Goodson was the embodiment of the dedicated master clinician, and at the time of his death, his family, patients, colleagues, and friends established this educational program to perpetuate his spirit of inquiry, discovery, and commitment to patient care. The Goodson Lectureship has brought some of the country's finest internists to Kansas City. In my 35-plus years at UMKC, the Goodson lecturers have been among the most memorable and impactful upon me and my peers. In addition to the lecturers, each year we also have been honored to be joined by numerous members of the Goodson family, including Dr. Goodson's 4 children, Grace, Liz, Bill, and John. This year, John and Grace are joining us remotely from their homes in Boston and Alabama. Liz is here. And it's my distinct pleasure to introduce Bill, that is to say, William H. Goodson III, as this year's Goodson Lecturer. Dr. William H. Goodson III is a Kansas City native who pursued undergraduate studies at William Jewell College and the University of Missouri before attending Harvard Medical School. He completed clinical training at Washington University, Case Western University, and the Boston Children's Hospital. He was professor of surgery at UCSF, where he was the chief of the breast center, and he chaired key medical school, departmental, and hospital committees. In 1997, he joined the California Pacific Medical Center Research Institute, where he is a senior scientist and has extensively studied the impact of environmental chemicals. With over 40 years of clinical experience, he has been a pioneer in breast cancer care and research. His work helped establish breast conservation, i.e. lumpectomy, as a standard treatment for early breast cancer, and he is an expert on the effects of environmental chemicals on human health. He has published over 100 scientific papers and was the lead author of the capstone summary of the Halifax Project, which assessed the carcinogenic potential of exposure to chemical mixtures in the environment. Dr. Goodson has spoken internationally and received the Compassionate Caring Award from the Institute for Health and Healing. He is also active in the arts, including writing, with 2 novels under his belt that I'm aware of, photography, and hand-drawn animation, which is showcased on his website, www.drwilliamgoodson.com. For 39 years now, the Goodson Lectureship has been an annual highlight for our faculty, residents, and students. Please join me in welcoming this year's speaker, Dr. William Goodson.
Thank you, David. So, it's a pleasure to be here. It's an honor. It's an honor to speak at UMKC. It's an honor to come back home and have people pay attention to you. It's not always where the prophet is not without honor in his own country. So I feel like I'm getting something here that's very special. So what I'm going to talk about is environmental chemicals. Everybody hears about them. I'm going to talk to you about them, and I hopefully will introduce some thoughts that you haven't thought about. So to begin, I want to give a special shout out to Shanaz Derki, with whom the middle portion of this talk, without whom the middle portion of this talk would never have happened. She's a very brilliant woman, and we've collaborated for, I guess, now 19 years, and worked well. I have no financial disclosures. So, take-home concept. I've come to the conclusion the way you give a lecture, you tell people what they're going to know at the end, so they at least know what I'm trying to tell them. And I will come back to this slide, but basically the usual explanations do not account for all the increase in breast and lung cancer. We're exposed to multiple chemicals that can adversely affect our bodies. Carcinogens cause more cancer without causing more mutation, or can cause more cancer without causing more mutations. We all grew up in the idea, oh, cancer is a mutation, and this is going to do it. You know, something's mutate. You actually, as I will show you, you can have things which are not mutagens cause cancer. And then racial disparities may, in fact, reflect exposure disparities. So the organization of the talk, I'm going to start out and talk about why the usual explanations are not as much an explanation as you would think. I'm going to talk about the benefits of switching personal care products for young women, and I'm going to talk about how air pollution in PM 2.5 can affect more than lung tissue. So this is the standard chart that's shown all the time. Increase in breast cancer between 1973, peaks in 1999, drops and comes up. Most people concentrate on this part, and when you hear people talk about it, and they say this increase is because of the overdiagnosis with mammography. That's a very common statement, and I'm going to explain to you why I think that is incorrect. And actually, it's not only just me. And just for reference, SEER is Surveillance Epidemiology and End Results. It's an NCI thing that surveys cancer data, and I guess it's up to 23 areas now. It was originally 6, and they've just these massive tumor registries all over the country. So a couple of things come out in the course of looking at SEER. If you ever want to really play around with something, Google SEER and get on the website, and then once you're on it, you can do breast, and then you can do a whole bunch of things, but you can play around with it and come up with some things which are kind of both interesting and then disturbing. This is the incidence of breast cancer in Caucasians in the United States from 2000 to 2022. There was a drop, it's gradually come up. This is the incidence of breast cancer in African American women in the United States. The others are much smaller groups, but those are the two largest groups in the United States. And what's very clear there is that African American women per capita have less breast cancer than do the Caucasians. The companion observation, which is the one that's more disturbing, is that although they have less breast cancer, African American women have a shorter survival. The way to understand this slide, it's the survival from 2012 to 2022. The 10-year survival is planted here. This is from 2021, 2020, et cetera. So you can see how the survival is consistently lower, and we're going to talk about that toward the end of the talk, but I'm going to give you some background first. If you look at the increase in breast cancer across the board in the general population, so-called, let's see, this one is HER2 positive, this is HER2 double positive, or hormone receptor positive, and HER2 positive, and the green one is triple negative. Well, what we call triple negative, they only plot it as hormone receptor positive. We call it triple negative because it's ER negative, PR negative, and HER2 negative. These groups have actually been fairly stable. The difference is an increase in hormone responsive breast cancer. And therefore, you know, people start to wonder what would drive hormone responsive breast cancer. There's one other thing to look at here. And then look at the general population, the rate of triple negative breast cancer, which is the worst kind out there, is at about 15 per 100,000 women, and fairly constant at that level. If, on the other hand, you look at African American women in the United States, breast cancer has gone up in the hormone responsive tumors, and this is pretty much like with everybody else. Unfortunately, and the thing that I will come back and address at the end, is that the incidence of triple negative, the worst kind of breast cancer, is about 10 per 100,000 more in the African American women living in the United States. And this is something that I think has at least things to think about, as I will discuss later. Now, the proposed explanations for why there's more breast cancer, it's always said overdiagnosis, finding irrelevant cancers through excessive screening, issue of obesity, alcohol, sedentary lifestyle, hormone therapy at menopause, deferred childbirth, and not nursing children. Each one of these you can find is a little bit of a factor. The difficulty is that starts in 1973. The increase in breast cancer actually started about 1950. It started 25, 30 years later. This is Dahl and Pito. Did anybody know who Dahl and Pito are? Richard Dahl, Richard Pito, they were knighted. They were the British physicians who figured out that cigarette smoking causes lung cancer. So they're a big deal. They really are very, very important in the history of cancer. But in 1981, they put together this monograph in which they looked at the incidence of breast cancer. And what they were looking at was the Connecticut Tumor Registry and the upstate New York Tumor Registry, dating back actually to the first National Cancer Survey in 1937. And what they showed was that there's an increase in breast cancer that started really right after World War II. And this kind of gets lost. And they looked at this and say, well, this is because people are becoming more obese, they're inactive, they're drinking alcohol, and oh yes, we're overdiagnosing things which are not really important. And so this prompted some blowback, but the most important part of this is there were several groups that went through and say, okay, if we're overdiagnosing things, then we look at autopsies, we should find a lot of women who had breast cancer that wasn't known before they died. So this is a series of autopsies that have been put, start actually in the second line, 55 to 65, 10 years in Boston. Coroner's autopsies, 40% are women, so this comes out at about 4,500, 14 cancers, so there's 0.3% of the forensic autopsies done in women in Boston at this time interval found a cancer that was not previously identified. The New York study series is actually twice as big, but if you take roughly the same 40% estimate, you get 8 cancers they found. And this was back in an era when somebody had an unexplained death and the coroner did the autopsy. They really did an autopsy. They took things apart, and that's not really done that way these days. You have similar data from Ohio, Denmark. The study in New Mexico was the one that's probably most commonly cited. And again, that only has about 1%. This one is also the one that categorizes the number of pre-malignant things, atypical hyperplasia, ductal hyperplasia, and stuff like that. The point of this slide is that, okay, there are a few cancers that were not known when people died in an era before widespread mammography, because you notice all these things ending up in the 80s. So that it's a little hard to argue that there was this huge undiagnosed pool of breast cancer when you compare it that way. Now, the next point to start thinking about other things that kind of throw a wrench into this argument is to look at the incidence of invasive breast cancer in women under the age of 40. Women under the age of 40 are not screened for breast cancer. Mammograms is a debate as to whether or not you start at 40 or 45, but nobody's recommending routine mammography under the age of 40. This is the incident. Cathcart Rake is over, actually was at KU. She's now going to the Mayo Clinic. But she actually was the first person to point out that the incidence in younger women of breast cancer has gone up at a pretty constant rate from 2004 to 2017. This number actually, you can go to the, I use this because it was her recognition. The follow-up data is that it actually starts going up at a faster rate in 2018. So you have this group of women who clearly have more breast cancer who are not being screened. So something is going on. And a couple of other things that are really hard to ignore. Everybody's heard of BRCA1 and 2, right? Okay. Have you heard of PALB2? PALB2 is positioner and localizer of BRCA2, and this was first described in 2014. And this is a gene that had not been associated with breast cancer before. There's no extra screening for these women. And the striking thing here is if a person had this gene and take the relative risk, and they were born before 1940, if you take that as the baseline risk, if they were born between 1940 and 1959, they had almost 3 times the risk at the same age of breast cancer. And if they were born after 1960, they had 6 times the risk of getting breast cancer. So something had changed that has nothing to do with screening. It has to do with something around them, at least what they're living through. A similar study was actually done a few years earlier where Mary Claire King up in Seattle looked at women who had a BRCA mutation. And if they were born before 1940, they got more breast cancer. It got up to about 80%, but you have to live to be 90 years old to get to about 80%. If you were born after 1940, you hit 80% risk at about 55 to 65. So something has shifted, something has changed that make it so that women get breast cancer at a younger age with the same genetic mutation. So the other part of this is to look, if you go, I'll show it, match it up in a minute. When it showed the red line with the risk going up, there's a little blue squiggle along the bottom. That's male breast cancer. And if you look at male breast cancer compared to women's breast cancer, it's a flat line. You don't notice the change. But if you go down and take that line and magnify it, the red line on this would be somewhere about the ceiling. If you take the blue line and expand it, you realize the incidence of male breast cancer has gone up at a constant rate over the same 35 years. So something has happened that affects males. And you get right down to it, males don't take hormone therapy at menopause. They don't defer childbirth. They don't have any screening program. They don't not nurse their children. And they may have a little bit more obesity, a little more alcohol, a little bit more sedentary lifestyle, but that was already blamed for the increase in breast cancer between 1950 and 1973. You can't keep trotting out the same thing and say, this was an increase and oh yeah, get more increase, because alcohol consumption is actually up a little bit maybe in young women is up a little bit, but across the board it hadn't changed that much. So what you're left with is environmental exposures, and this is a shout out to Anderson at MD Anderson of all places, who actually first raised this idea in 2010, 15 years ago. Now, one of the other fun things you can do with PowerPoint is you can take illustrations and adjust the X and Y axis. So if you adjust the X axis for the SEER data and sort of shrink and adjust the X-axis for the Doll-Peto study with Connecticut and New York and make it so this 25 years matches this 25 years, and then also arrange the Y-axis, all of a sudden what you have is a graph that covers 75 years. And I don't think there's any smoke and mirrors in this. It's just that there is 2 graphs back to back that show an increase in the risk of breast cancer in the United States that's very constant. Now, it is true that mammograms, there was a huge impetus on doing mammography in the 1980s. That may cause this boost, and if what they were doing is finding things that would show up later, that might explain why this goes down a little bit. But it's much more complicated than that, because you look at all the things that are going on here. First of all, phthalates and parabens, 2 very common plastics. Phthalates were invented in the 20s and started being used in food and processing things in the late 1930s. 1937 is the one reference I could find. Premarin, you've heard of hormone replacement therapy. Apparently nobody thinks about it as Premarin anymore, but when I was growing up, Premarin was it's conjugated equine estrogen. It was the most common form of estrogen prescribed, and Premarin came on the market in 1942. Important point about that is Prempro, which is the combination estrogen-progesterone, was not actually marketed until 1995. People did some studies with it, but the actual marketing was in 1995. Oral contraceptives came very first oral contraceptives marketed in 1960. The peak in in oral contraceptive use was about 1973. It kind of went up, and it wasn't a peak and went down. It just went up and became a fairly constant number, at least up to 1990. So the use of oral contraceptives is kind of like it's a population that grows, and then it's a population that women get older and they don't need their oral contraceptives, or they decide to do other things. But oral contraceptive use was here. But within a couple of years, you had the low-dose oral contraceptives. Now, the early contraceptives did have some associated with increased breast cancer. That's very hard to demonstrate with any of the low-dose estrogens, so that the low-dose birth control pills from here on out probably are not a factor. Parabens, methylparaben, ethylparaben, et cetera, started being used as preservatives in cosmetics in the 50s. Polycarbonate plastic, which is BPA, was invented in 1953 and very rapidly became used for all sorts of things. And final little bit here is a couple of years ago, there's great excitement. You had the Women's Health Initiative. Everybody should stop their hormone replacement therapy. And, oh yeah, breast cancer went down after this. The difficulty is that the peak incidence of breast cancer was around 140 cases per 100,000 in 1999. There are 3 years, 2000, 2001, and 2002, decrease before the publication of the Women's Health Initiative in the summer of 2020 and 2002. So you get 2.5 years of decrease before this is even published, let alone has any effect. So you've got a kind of the argument that Women's Health Initiative led to reduced use of hormone replacement therapy, and that's why it dropped, doesn't make sense, because the decrease occurred the first couple of years before that. And then probably most important is, despite all of these things, the increase in the risk of breast cancer in women has continued to increase, and this is 22. 21, the rate was back up at 140 per 100,000, which is basically the highest it had ever been in 1999. Other things that are important here is that DDT was released as a civilian drug. It had been used by the military, but in 1945, when the war was over, it was used for civilians. The important thing to know is DDT is the gift that keeps on giving. You hear about PFOA as a forever chemical. DDT is a forever chemical too. A few years back, well, it's about 15 years now, a group of doctors bought salmon all over the world. They bought commercially farm-raised salmon. They bought wild-caught salmon. All of them have DDT in them. And it's like, DDT is out there. If you've had salmon in your life, you've got DDT in your body. It just gets there. There's no way to get it out. So it's not just mammograms. You've got a whole series of things that you have to sort of think about. So I would argue that your increase began 30 years before any widespread use of mammograms. The BRCA1 and 2 and the PALB2 carriers get breast cancer when they're younger. There's an increase in women under the age of 40 who don't have screening mammograms or otherwise. And delayed childbirth and oral contraceptives have been around longer than the last decade or so, and they also don't affect men. So come back to the slide I showed you a while ago, and that is that every kind of breast cancer has pretty much stayed the same, except as hormone-responsive breast cancer. So why would that be an issue? How does that happen? And go back almost 100 years to a guy named Edward Dodds. And Edward Charles Dodd was really a bright guy. And he started with the observation that there were 5 distinct chemicals found in nature which would have an estrogenic effect in mice. What he did is he removed the ovaries from mice, let them get over that. The mice had no hormones, and the vaginal epithelium would not be keratinized. That's what, it's an important thing for vaginal epithelium to be keratinized, because if a woman loses that, which is sometimes what happens in menopause, it can be very uncomfortable. The keratin is the tough stuff that makes it so your finger, when I rub my finger here, the skin doesn't fall off. It's not because of the epithelium, it's because of the keratin. It holds it together. So he made this observation, And having done that, he started saying, okay, what else works? And it's kind of funny to read his lab books. This one shows sesame oil. He tried diesel fuel. He tried nicotine. Phenanthrene ring is the basic structure of estrogen. And there are two things about it. One is he tried all sorts of things. And two, his endpoint was looking for keratinization of the vaginal lining. He was testing chemicals and he's deciding it was an estrogen on the basis of what it would do to the vagina of a mouse. Now that's very important, we'll come back to that. But anyway, meanwhile, what he did is, one of the things he found that dihydrodiphenyl worked as an estrogen. This is the structure of estrogen. Doesn't really look like it, but it works that way. He then took this chemical called bisphenol A, or BPA, which had been synthesized by some German chemists about 50 years earlier, and found out that that was an estrogen. And about this time, other people, not him, but other people had worked out the chemical structure of estradiol. And he kind of looked at this and looked at this and looked at this and said, you know, if I put a couple carbon atoms in here, I get a shape. And I think this is brilliant. He looked at it, the shape, and said, you know what? I can make this more like an estrogen. And what he did is he came up with DES, diethylstilbestrol, which is really the strongest estrogen that anybody's ever come up with. Any guys ever encountered DES before, heard about DES babies or anything like that? Okay. I'm going to give you a little history of DES. A short course of DES can change somebody's entire life. And the first thing to bear in mind is that Dodds was not trying to do anything with women at all. He was trying to find a way to treat bone pain from metastatic prostate cancer, and it had been figured out that if you gave a man with prostate cancer and bone pain a lot of estrogen, the pain would go away. And this was the go-to treatment from the 1930s to about the mid-90s when the LHRH agonist came on board. Unfortunately, the Smiths in Boston got the idea that, this is a strong estrogen, it must work to prevent miscarriage. And so they advocated and convinced a lot of people to give women DES, during pregnancy to, quote, prevent a miscarriage. And millions, literally millions of women around the world received this. The interesting thing was that Dodds was somewhat altruistic. He did not patent the drug. So anybody, you can make it in your basement if you wanted to, kind of like drug dealers these days. But a lot of people made estradiol. There were a lot of brand names on there. In the late 60s, somebody actually did a study to see whether or not it made a difference. Now, the study has some problems. We can get into that if you want to ask me about it. But basically, they didn't find any benefit in terms of reducing miscarriage. The worst part, however, is in the 1970s, that they started seeing almost an epidemic of clear cell carcinoma of the vagina in teenage girls whose mothers had taken DES. The clear cell carcinoma of the vagina was like described, but there have been like 10 cases in the world. And here this guy in Boston, I can't remember his name right now, actually had like 11 cases over the course of a year. And this became a recognized side effect, and in fact, people stopped using it when the FDA said you can't use it that way anymore. Two things that are important. One is, remember I told you that Dodds was looking for the vaginal epithelial effect on keratinization? So why in the world would anybody be surprised that this wouldn't do something vaginally when the little girls grew up? And secondly, the other part of it is that the moms had more breast cancer in the 90s, and in the early 2000s, they were able to find that the daughters who grew from these pregnancies had an excess of breast cancer. So a short exposure to a strong estrogen can actually cause a lifetime of change. So I think hopefully I've convinced you that the usual explanations do not explain the increased risk of breast cancer. How in the world do you design an experiment to do that? How do you design an experiment to test, okay, I think chemicals are bad for people. How do you design an experiment? I can't walk up to a group of women, recruit a group of women and say, okay, I want you to take this stuff that's bad and see if you get more problems or even have something adversely happen. So we came up with a different way of looking at it, and that is that for better or worse, many of you who use personal care products this morning, cosmetics, shampoos, deodorant, and skin moisturizers, had your daily dose of either parabens or phthalates or a mixture. Thank you very much. I love that, David. And turns out that one of the big sources of exposure to parabens and phthalates is personal care products. So we came up with a study in which we would ask young women to let us buy them. You know, we gave them the money, took them, or actually didn't give them the money, we took them to Whole Foods and literally bought the paraben and phthalate cosmetics and supplied them with $100, $150 worth of cosmetics for the next month. And the rule, the agreement was that they would stop using what they were using, and we kept track of all this stuff. What we then did, what's going to be your endpoint? And our endpoint was to do a fine needle aspiration, a little needle biopsy on these young women, and we had to convince them that it would work, but we did enough women, and nobody didn't come back for the second time. So we would do one study and get an aspiration. We went 4 weeks without the phthalates and parabens, and then we would do another aspiration. So we could compare the cells from the breast before and after this 4-week period. First of all, we showed a significant decrease in 4 cosmetic-associated parabens, methyl, ethyl, propyl, and butyl, and 1 cosmetic-associated phthalate. We found no change in the phthalates that are more commonly associated with food. And what we used, as I said, we used fine needle aspiration. So you have the cells on the fine needle aspiration, and this is where Shanaz could work wonders. She could get these things to grow, and we actually could, use SNPs and prove that these were cells from individual women and prove that it did not match any cell cultures. So there wasn't lab contamination. We were actually growing cells, and if you put them in Matrigel, which is basically a collagen gel, they would grow little spheres with the nucleus lined up on the inside. So we knew that we had something that worked, and what we did is we looked at differential expression. What that means is the expression before, the gene expression afterwards, remembering that gene expression is reflected in measuring total RNA, and what the difference is tells you which genes are differentially expressed. We looked at 567 genes at the 0.1% level. That would mean that you would have 6 genes that would happen by chance, that you would think, okay, if we had 6 genes, we'd say that's just random. What we found was 26 genes, 4 times as many, that were changed by the change in exposure. 18 were decreased and 8 were increased. Most of those that were decreased were ones where it was beneficial, some where it was increased. It might have been better to have left it high, and some that were, went up were ones where it was good, and some that would have been better for them to have stayed low. So we had this mixed thing, and the way it works out is that, it's not a clean, everything is one way, everything another. But if you're involved in oncology these days, we had hormone treatment, and then you went through a bit with mTOR and everolimus, and now the new thing in treating cancer, at least breast cancer, is PI3K mutations and AKT pathway mutations. And if you look at that specific pathway, of the genes that had reduced expression in that pathway, all of them were genes that would promote cancer. So when you reduced it, you were actually going in the right direction. Of those that increased expression, 1 of them would suppress cancer, so that was a good thing. So of these 8 genes, 6 of them were definitely beneficial. 1 gene, the effect may have been one that would drive cancer. And in order to sort that out further, what we did is we looked at actual function of cells. We had gene cells we looked at for genes, other cells that we grew in the laboratory, and we could look at how the change in the cell's function was. The most notable thing is that when you expose normal breast tissue to tamoxifen, it's supposed to die. The epithelial cells will die. The more chemicals you have around, the fewer cells die. And if you reverse that effect, you get more cells that die, so-called programmed cell death or apoptosis. That went up after the intervention. And the other thing is that Normal breast tissue has it hasn't made the world of oncology very much yet. It will be. But there are two types of estrogen receptors, ER beta, ER alpha. ER beta is typical of benign tissue. ER alpha is typical of cancer. And what happens was that when you go through this whole process and get the women to change their cosmetics, you had a decrease in ER alpha, the bad stuff, and you had a balancing increase in ER beta. So the study is small. Unfortunately, we were kind of cut off by COVID because we couldn't ask women to come to the office for an elective thing during COVID, and have not been able to get it restarted. But it's the only study like this out there that looks at actually changing something in people as part of an experimental process. And the answer is not what you would like, or at least not very reassuring for continuing life as you were. So, as I said, we've talked about the benefits of removing phthalates and comments in normal normal care products. And then finally, I'm going to talk a little bit about PM 2.5. PM 2.5 is the most active part of air pollution. It's been associated with asthma, decreased lung volume in kids growing up near freeways and things like that. And so what I'm going to talk a little bit about is PM 2.5. And it's a background for coming back to the fact that African American women have less breast cancer, but also poorer survival. That's where I'm headed. So Hill and Lim, who were in the UK, made the observation that lung cancer in never smokers goes up according to the amount of exposure in their community to PM 2.5. And you can, in each one of these, as the exposure level goes up, there's an increase. There's more air pollution in Korea and Taiwan than there is in England. But in all three settings, as the air pollution went up, there was a significant increase in lung cancer in non-smokers. They said, okay, this is interesting. So if you look at tissue from people who are smokers who get squamous cell carcinoma of the lung, there's a fairly typical pattern of gene mutations. The tobacco causes a fairly similar pattern in most patients, and it's a typical thing. And they looked at these tissue from these women and said, whoa, they don't have that mutation pattern. And then it was kind of like, why does the the lung cancer go up and they don't have the mutation pattern like a smoker? And what they did is they played around with it, and they discovered that the non-smokers who were exposed to PM 2.5 who got lung cancer tended to have a mutation in EGFR, epithelial growth factor receptor. This was a constitutive activating mutation, so that they had a little bit of overactive EGFR all the time. And then they did a couple of really, I think, just brilliant experiments. And like I said, this I think is one of the most important papers out in the last 10 years for cancer anyway. And that is the control mice. They put the EGFR mutation into the lung of control mice, and the control mice had a little bit of lung cancer. The mice that were exposed to the PM 2.5 had a lot more lung cancer. So what they were able to show is the PM 2.5 does not cause a mutation. It builds on a previously existing mutation. And they said, okay, now what has happened? And they sort of they go through a lot of reasoning, but basically they thought that there was reason to think that this was because the PM 2.5 causes inflammation. So what they did in a follow-up experiment is they blocked inflammation with an anti-IL-1 beta antibody, which relates to the kind of cells that you find in lung inflammation with PM 2.5. This is a mouse that has the mutation, was exposed to PM 2.5, and you can see a fair number of tumors. This is a mouse who, during the exposure, not even continuing after, during the exposure, also received an antibody that blocked interleukin-1 beta. And you can see that there are no tumors, and the number of tumors per mouse, some didn't get it, but a lot of them did. There were no mice that developed a cancer if you blocked inflammation while they were exposed to PM 2.5. So it made a very strong argument that maybe what was going on in non-smokers was pre-existing mutations, and it's kind of like, okay, how does that work? The important part to realize is that all of us sitting in this room already have gene mutations. And the miracle part of this, it's, you know, people say, why does so-and-so get cancer? And I think the real question is, why don't we all get cancer all the time? This is 2 genes, and this is the estimates that Hill and Lim had for the number of patients who had, and note that it's not had the mutation, it's the number of driver mutations, which I'll explain in a moment. But they looked at the number of mutations that were in the EGFR and KRAS and showed that they went up over time. And so this raises the question, well, okay, how does that work? And just a little sidebar here, people talk about the hallmarks of cancer. A cell is not cancer and then, you know, becomes cancer. A cell acquires a whole bunch of things. It acquires the ability to have sustained proliferation, evade growth, resist cell death, dysregulated metabolism, inflammation, and tumor microenvironment are key things. But a cell has to develop all of these things before it becomes cancer. And the testing that is done for chemical safety in the United States is sort of positing, well, if a chemical does all these things and we can show all these things, okay, we'll call it a carcinogen. If it can't do all of these things, it's not called a carcinogen. And I think that ignores the fact that we all live with a lot of mutations. This is done with blepharoplasties. Plastic surgeons in, I think it was in the UK, but they, you know, when you do plastic surgery, you bring somebody's eyelid up, you're taking out a little bit of skin. So they collected the skin and they tested it for mutations. This is a 1 centimeter area, and each circle represents a specific gene, a clone of cells that have a mutation in a specific gene. For example, this is a clone of cells that have a mutation in fibroblast growth factor receptor 3. These are cells which are Notch 1 and 3. Notch 1 and 3 are important because they're some of the big driving mutations in squamous cell carcinoma. This is skin that does not have squamous cell carcinoma. This is skin that has accumulated mutations over a lifetime because you think about it, the eyelids are out in the sun all the time. But it gets a little worse than that. Same group went back and they looked at esophageal tissue from tissue donors, people who were having donate, you know, they were deceased, they were doing harvesting, and they got permission to, in addition to the kidneys and liver and everything else, they would harvest the small amount of tissue from the esophagus. Now, this is the number of mutations they found in a 20-year-old non-smoker. This is a 40-ish heavy smoker. Okay, buy that. The part that's more disturbing is this is a late 60s non-smoker, and this is a mid-70s non-smoker. We accumulate these things through our entire life, and we kick it off by things we're exposed to. Yazek went along and did this a step further. They looked at mutations in a whole bunch of tissues from men and women, and the highest number of mutations was in the esophagus, and this is sort of coded by the size of the little purple thing here. Lung and skin, skin is the highest, followed by esophagus and lung, which are about the same. The one that's interesting is the 4th highest mutation rate was actually in female breast tissue. All of the other tissues as marked had accumulated mutations over people's lifetime, ones that are associated with malignancy. This is not, you know, some little benign mutation. These are real mutations. And the only tissue in which they did not find mutations was the fallopian tube. Every other tissue sample, they found mutations. So we live, all of us, I mean, you guys are a lot younger than I am, and it always scares me to think about the number of mutations that are floating around in my body. But if you think about it, if I have that many mutations in my esophagus and then I irritate my esophagus with alcohol or reflux, you know, there's a reason that people get you know, esophageal cancer with reflux and stuff like that. They don't need to start from zero. All they needed to do was add inflammation to the pre-existing mutations. So this comes back to breast cancer. This is a study published 1.5 years ago, and what they did is they calculated the PM2.5 in the air from 1980 to 2010 using EPA, Weather Bureau, military sources, et cetera, in 2 cities, Detroit and Atlanta, and 6 geographically diverse areas of the United States. They had a big sample. Between 1995 and 1996, they enrolled 196,000 women who had no history of breast cancer or any other cancer in a cohort with the NCI and Association for Retired People, and followed these persons for the next 20 years. What they found was for every increase of 10 micrograms in a cubic meter of air in what they were breathing, there was an increase of 8% in increase in ER-positive, PR-positive breast cancer. Very clear relationship. They found no effect of the PM2.5 on hormone receptor negative breast cancer. So this is it's kind of like it matches up with everything else. You have, everybody's got mutations and you expose them to PM2.5. 2.5 not only, you know, you think about it a second, you've already probably heard that PM2.5 will lead to increase in heart disease, heart attack, stroke, and things like that. That's probably mostly an inflammation, but it definitely is not from direct contact with PMT from the air you breathe. It goes from the air you breathe to the lung, to the blood, to the heart. And if it can go to the heart, it can go anyplace else in the body. So this, I think, is a very important observation. And then the final paper I want to show you was published last month by the group at Memorial Sloan Kettering in New York. And they looked at the 5 boroughs of New York, and they categorized, they looked at all of their patient population, people treated at Memorial, and they also matched it up with breast cancer and what they had as a disadvantaged index, the disadvantage of the neighborhood. Now, the part that I know, this is Harlem, which is definitely a disadvantaged neighborhood. I can't really say that I know Brooklyn, Staten Island, back parts of Staten Island, I would agree, because this part's all gentrified. And Queens and the Bronx, I don't know them that well. But what they did show is that in these areas where you had a disadvantaged population, you had a higher incidence of triple-negative breast cancer. Remember I was talking about triple-negative breast cancer, the worst kind of breast cancer there is? And the 5-year survival from that cancer was lower than in other neighborhoods. So you have more of the worst kind of cancer, you have a lower cancer-specific survival, and it tags to the disadvantaged communities in the 5 boroughs of New York. So I've hopefully convinced you that you have to think beyond screening mammography for the increase in breast cancer. I hope I've convinced you to at least think about whether or not cosmetics and other exposures are things that one should be careful about. And it also, I want you to think about the idea that PM2.5 affects more than just asthma. And the take-home concept, usual explanations do not account for the increase in breast and lung cancer. We're exposed to multiple chemicals that can adversely affect our bodies. Carcinogens can act or cause cancer without causing mutation. I think that's a very important concept, and racial disparities may in fact reflect exposure disparities. So my last slide is one you can read yourself, and just remember there was a time that people made this assertion. Thank you. Yes.
You briefly mentioned that, you know, the U.S. government doesn't do a phenomenal job of regulating things unless they have all indications of being a carcinogen.
Yep.
So my question to you is, when you were selecting paraben and phthalate-free pharmaceuticals, was it reliable and trustworthy, the branding on the
Well, you hit on 2 issues. First of all, the FDA doesn't give a damn.
Yeah.
And so the FDA does not. There is a group called the Environmental Working Group, And they actually go out and buy cosmetics and then take them to their, independent testing laboratories and test them. So we use their website. Anybody can use the website, ewg.org. You can, my son pointed out, you can get an app. You can go to the grocery store. But if EWG says it's clear, then it tends to be that way. We use the EWG database to select the cosmetics that we would buy for people for this period of abstention. And we showed that the levels of the parabens and the 1-phthalate, the ones that are most commonly found in cosmetics, they showed that we went down. So we assumed it would go down, and then we proved it would go down. The background on this was a group of high school girls in Salinas, California, a little farming community, think John Steinbeck and stuff like that. They did a 3-day study. They recruited a whole bunch of women, classmates, so they all switched cosmetics for 3 days or gave them up for 3 days. And then they took 2 urine samples, one before and one after, and showed that within 3 days, most of this stuff is cleared. So it's not unlike the DDT that you had with salmon 10 years ago that's probably still with you, or the PFO, your mom's Teflon frying pan. You probably can clear your phthalates and parabens fairly quickly. But the government doesn't give a darn.
In the graphs, we talked about what probably have caused the increase of the incidence of cancer. What were we doing right when they kind of moved in the other direction?
I don't know that I know an explanation for why it peaked and went down. It peaked in 99, dropped down, and then started over on another curve. I kind of think of it as like Aricept or dementia. Aricept doesn't prevent dementia, it just shifts it 6 months or a year into the future. If you remember the ability with Alzheimer's this way and then move it over 6 months with Aricept, you're shifting it. And I think what happened is something shifted it. I don't know what. You could look at it and say, well, okay, that's probably maybe where the DDT contamination dropped off to a lower amount. There are a whole bunch of things that you can say, but I don't have an answer for that.
And then we said that these were not mutations that were increasing in number, but sounds like that we look for the mutations that we were looking for, and there could be mutations that we did not detect.
In terms of the PM2.5 and lung cancer in non-smokers, that's what I was trying to talk about. The point of all that was that we accumulate a lot of mutations. You have fewer than I have probably more than anybody else in the room, just because I'm older, but we all accumulate mutations. You could show a specific association taking, presumed mutation, EGFR, and put it into a mouse that didn't have that mutation, and it would make a few cancers. Then you came along and exposed it to PM2.5. But if you blocked the inflammation, you blocked the increase. So you did kind of fulfill the Koch's postulate of you can cause it and then you can take it away. And if you can do that side of it, probably relates. You had another question? Okay. Yes, Dave.
I couldn't go into ophthalmology because I find it really hard to spell. I don't think I could be studying environmental chemicals because I can't spell phthalates for the same reason. I wonder, I overheard a conversation this morning. You enrolled your son in a study. So it occurs to me that there's other things in the environment, like there's these few things that you've been able to identify, right? There's PM2.5, there's the parabens and the phthalates and so forth, but there's all this other stuff in this soup that it's.
Well, the study I think you're referring to is that I knew a guy in the ag school up at UC Davis, and I said to him, we're testing these chemicals. We want to test a chemical, and he said that don't test the chemicals. He said he's much more concerned about the hormones in dairy products, and I said, well, wait a minute, no, all these things are hormone free. Turns out it's not, because the definition of no growth hormone means that the cow didn't receive growth hormone. But the way commercial dairies are done in the United States, even, quote, organic dairies, is the cow has a calf, they then start milking it, they breed the cow at about 90 days. So the cow has just come off being pregnant, and then for about the first 6 months that the cow is pregnant, it's natural, but it's the natural progesterone. And so you actually have progesterone in your dairy products. I actually confirmed this with a woman who runs a big organic dairy cooperative north of San Francisco. I just asked her, she'd shoot me if I said this. But I said, are your cows pregnant when you milk? Oh, yeah, you get more milk. And that way, if the farmer has a cow for a year and is milking the cow and then can have the cow be growing another calf, that's just good economics. But what it is there's a fair amount of progesterone in cow milk. And back in the 70s, there was a description of a way to test whether or not a cow was pregnant by doing immunohistochemistry analysis for progesterone. So we wondered, gee whiz, does this get absorbed? So what we did is, it's going to sound terribly sexist, but trying to estimate progesterone levels in a series of women, even if they have a regular cycle, you don't quite know where the progesterone levels is. So we did this in guys, just sort of proof of principle. Recruited a bunch of guys to come to my office, absolutely no dairy products of any kind for 48 hours. And we had them spit in a tube, measured progesterone, sent them out for 24 hours to imbibe imbibe high-fat dairy products. Cheese, butter, milk, whole milk, pancakes, the whole 9 yards. And what you showed is that I don't see a pen here, it's all right. You got a marked increase in the progesterone level in salivary progesterone. Remember, salivary progesterone hormones in saliva are actually a pretty good indication of what's in the body, because in your blood, a lot of your hormones are bound to sex hormone binding globulin, and then a small part of it is free, but it's the free hormones that make a difference. The free hormones get into your saliva as a transudate going between cells in the epithelium in your salivary glands. So we could show that the progesterone went up, and then we measured them 24 hours later and it came down. And then we had them come back a week later and do the same thing. It would down and go up and go down. So we had a very striking set of double curves. And it really is, the thing to remember from your chemistry, progesterone is fat soluble. So it partitions to the fat. So we were using butter, whole milk, and stuff like that. If you're going to drink milk, I drink milk products, but I also drink low fat, and because I think that's the wiser choice. But we get exposed to things in ways we're just not even thinking about. And it's not because it's not organic, it's because the cow's pregnant. Pregnant women have progesterone too, as do pregnant cows.
If you ever have a need for external validation and you want to test a Kansas City population to see how it compares to the San Francisco population, I think I could round up some volunteers for you for an ice cream binge.
Well, I think it'd be fun. I've always thought about getting
Any raise or I don't know.
getting a kid's soccer team and do it, and then have them, binge on pizza and do it. You got to think about the image. This was in my office. I do breast cancer, so this was a Friday afternoon, 5 o'clock. Everybody's gone home, and you got a bunch of guys sitting around. You can imagine the humor. And so it's, yeah. If you want to work it out, I'll tell you how to do it. I can tell you where to get the testing done and everything. I'll even pay the money if you want to. Anything else? Well, thank you all very much.